Good evening, everybody. I would like to welcome all of you to this, in fact, the third session on Adrenal. We honestly didn't expect this to go on for this long. Perhaps we are reaching a state which is probably not required for MS or DNB level, but it's never wrong to learn a bit more than what you actually need. And so we have, as you know, we looked at the anatomy and physiology. We looked at some of the lesions last time and the functioning of the adrenal. And today we're going to talk about adrenal tumors. And we're happy to have our endocrinologist, Dr. Swathi, with us. She has been kind enough to accept to give us a little presentation, maybe lasting 20 minutes or so, on her experience as an endocrinologist and her approach to adrenal masses. But later on, Pawan is going to talk a little bit about a surgical aspect of it, what the surgeons think about it. And you will probably find that as we go along, there is a little difference in the approach, particularly for the non-malignant hormone-producing tumors. Physicians tend to conservatively manage them, and surgeons, by and large, recommend excision. But that is a bit of a subject for debate, and of course we can have that kind of a discussion as we go along. But first, before I ask Dr. Swathi to start, Pawan has done a lot of work and he has a lot of slides on it, and we may not be able to cover it, and we have a policy to stop at about 1 hour, not go on and on. And so we may extend to another class after this for completion of this session. All right. And so may I now welcome Dr. Swathi to give her presentation, please. Dr. Swathi.
Thank you, sir. Thanks a lot. I understand the time limits that we are looking into, and I'll try to finish it off in 15-20 minutes. We have already discussed how we approach hormonally in terms of evaluation of an adrenal mass. In this presentation, I will just quickly go through it and share our original work on few aspects of adrenal masses, especially the radiological aspect as well as the bilateral adrenal masses. When they come, how differently do we look at them? So I hope this time my slides, audio, and this thing would be visible.
They're very nice.
Go ahead? Very nice.
Please go ahead.
Yeah. So adrenal mass, as we had discussed last time also, we encounter adrenal mass in two circumstances. First thing is we seek out the mass. That is, whenever there is a hormonal hypo or hyperfunction of the gland, like if there is a Cushing syndrome, obviously patient walking, or if there is a adrenal Addison's disease, that is the time when there is hypo or hyperfunctioning of the gland that we order adrenal CT, look at it, and then characterize the mass. But more common scenario is this nowadays, with so much of use of CT scans, we generally the mass seeks us out for some unrelated indication. Unrelated with that, I mean that the imaging done not with expectation of any adrenal pathology, that we do an imaging under so many pretexts, as a routine checkup, as a renal colic, as menorrhagia workup. For whatever reason we do imaging, we find an adrenal tumor. So this is something which has become more common now. So these incidentalomas, as the definition goes, they can be unilateral or bilateral. When it is unilateral, there can be any of these hormonal hypersecretory tumors like Cushing's, Pheochromocytoma, Conn's tumor, or an ACC, adrenocortical carcinoma, and a lot majority of them are actually non-functional. But when it comes to bilateral adrenal masses, in addition to the tumors, there are other pathologies which take upper hand, like infections, infiltrations, metastasis, and sometimes hyperplasias. So in the presentation later on, I will be discussing our experience about bilateral adrenal masses. But whenever we encounter an adrenal tumor, the major decision that we have to make is whether we need to operate or we can wait and watch and observe. So, and the factors which determine our decision are, first and foremost, is whether the mass is secretory or not. hormonally hyperactive or not. And last time we had discussed, I will not go through these details again, as to which kind of hormonal hypersecretion syndrome, either Conn's or Cushing's or Pheochromocytoma, what are the biochemical tests that we need to do to establish the diagnosis, and what are the precautions that we need to undertake while we order those tests. And the minimum endocrine evaluation that we look at is a overnight dexamethasone suppressed cortisol levels, plasma-free normetanephrines for Pheo, and in hypertensive patients with an adrenal mass, we have to do an aldosterone and renin ratio. Needless to say, electrolytes are also very important, which give us some information. I want to spend a half a minute on discussing that what if we don't find out the secretory nature and go ahead with the surgery. So what are the implications of operating a secretory mass vis-a-vis operating a non-secretory mass? So if we consider Conn's syndrome, which is a mineralocorticoid secreting tumor, perioperatively we expect hyperkalemia, because if we remove the tumor, the other adrenal is suppressed, and they can go into a transient phase of hypomineralocorticolism, and that can present as post-operative period hyperkalemia, difficult to control hyperkalemia sometimes, and a slight rise in creatinine. They can go into an acute kidney injury. So that is important. It's actually a benign thing, but I mean, counseling the patient about these complications may help. And there might be a need for starting fludrocortisone or mineralocorticoid in immediate perioperative period if these complications arise. In Cushing syndrome, there can be a risk of going into post-operative adrenal crisis, because the other adrenal remains suppressed, and it may take anywhere between 1 month to 18 months for recovery of the other adrenal function. So post-operatively, we can have a hypotension and hyponatremia and an adrenal crisis if the tumor that we had removed is actually cortisol hypersecreting. And Pheochromocytoma is well known that if it is a Pheo, we have to prepare the patient preoperatively by adequate alpha blockade. Nowadays, calcium channel blockade is also there, so that we can avoid the massive surges in PP intraoperatively and the post-operative hypotension that happens after the tumor has been removed. So there are perioperative implications, knowing beforehand whether a mass is secretory or not. The second important decision-making factor, apart from the secretory nature of the tumor, is whether the tumor is benign or malignant. And for that, the greatest help which we seek is from the radiology. So I'll discuss these two cases that we had come across. Representative one. So this was the patient, 49 years old. He was operated for CA penis recently. And during that workup, a CT scan was done, which showed this left adrenal nodule. And then he was referred to us. Now here it is important to know, in the given setting, one is very tempted to think that it might be adrenal metastasis. And not only that, it will have implications on how further that the staging, upstaging of the tumor, and how that management strategies might differ. And more important for us is to know whether it is Pheo or not, because if metastasis, this is a scenario where we do go ahead with the biopsy to prove that it is a metastasis. And if it is a Pheo, we may not be very keen on putting in a needle there. So such are the circumstances where preoperatively knowing the character of the tumor, and especially to rule out Pheo, becomes important. Another scenario, a 38 years old male who had left orbital bone infiltrative tumor, which ultimately proved to be a lymphoma. And he received FDG PET CT was done, which was suggestive of a lot of disseminated disease, lot of lymph nodes all over the body. Along with that, there was a left adrenal mass, which was detected on the staging FDG PET CT done before chemotherapy. He received 6 cycles of chemotherapy. After chemotherapy, when the FDG PET CT was repeated to know the disease response, all other masses has resolved except for this left adrenal mass, which remained exactly the same as it was in the pre-chemotherapy FDG PET CT. Again, the question comes whether it is really a lymphoma, and it can be labeled as a resistant disease, and the lymphoma management has to be upstaged, or it is something else and we need to biopsy it. Again, if there is a question of biopsy, it is important to know whether it is Pheo or not, whether we can safely put in a needle or not. So with this two cases which put forth the importance of knowing what kind of tumor it might be, I would like to discuss that adrenal incidentalomas, when they come across, they have become very common, and the approach depends on whether it is an adenoma or whether it is a non-adenoma. Adenomas comprise 80% of the adrenal incidentalomas as against non-adenomas, and non-adenomas can be adrenocortical carcinomas or metastasis or pheochromocytomas, and there is a list of other benign pathologies which are rarer. And the key is radiology, the way we look at it. And as the literature has evolved, the radiological, the CT scan, differentiation of adenoma versus non-adenoma was best given by a baseline HU of the adrenal gland in a non-enhanced phase, baseline. And the 10 was considered to be a good threshold that could diagnose if any adenoma has a baseline HU of less than 10, as we know, it has got 98% specificity that it would be a benign adenoma. Problem was 30% of the adenomas are lipid poor. That means they will have the baseline HU of more than 10. So in that scenario, then later on as the literature evolved, there came the concept of washout, that we do a baseline HU, we give a contrast, and in different time periods after the contrast, we take HU and then calculate the washout percentages. And in multiple studies, it was replicated that these washouts perform really very well to differentiate benign from non-benign, that is non-adenomas, especially when the non-adenomas consisted of metastasis. What I mean to say is, to differentiate adenoma versus ACC, adrenocortical carcinoma, and metastasis, the washout percentages behave very well. We get some idea about whether it could be a benign or not. But what about pheochromocytoma? So as I discussed, that knowing preoperatively that it is pheo helps us. And is there any radiological characteristic which can tell us that this is pheo and not adenoma, or the classic non-adenomas like ACC and metastasis? And because pheochromocytomas can have good washout as well as they can be poor washouts. So it is a overlap. And moreover, the differentiation of pheo from other non-adenomas like ACC and metastasis radiologically is scarcely studied. Second important point is that these washouts percentages which had been studied, they are especially in the washout phase. What I mean to say is, after we give the contrast, the mass takes up the contrast, and once it has maximally taken the contrast, when it washes out, that is what we study, washout percentages. But wash in parameters, that is from baseline phase, how much contrast the mass has taken, those wash in parameters are rarely studied in the literature as such. So we decided to study these wash in parameters, and we decided this study at KEM Hospital in Mumbai, in my previous institution, where we aim to study the wash-in characteristics that could distinguish the pheochromocytoma from other non-adenomas, that is metastasis and ACC and other things. It was actually a retrospective chart analysis for our patients. And in the 3 years period from Jan 2013 to 16, we had around 159 masses, and the final cohort that we could make use of, in which all the 4 phases were available of adrenal CT, we included around 72 adrenal masses in 66 patients. Our cohort consisted of 33 pheochromocytomas, 22 adrenocortical carcinomas, 4 lymphomas, adrenal lymphomas, and 13 adrenal metastases. Our CT protocol is the typical adrenal protocol that we all know of, that we take the first phase as unenhanced phase at 0 minutes, and at 20 seconds we take the arterial phase. Then at 1 minute we take the early venous phase, and a delayed phase we take at 15 minutes. And we calculate the conventional washout parameters, relative washouts and absolute washout. But what we did in this study is that we studied some wash-in parameters. That means we study in which phase the mass has achieved the maximal HU, like arterial phase or early venous phase, where the mass has achieved the maximal HU. We also we actually devised this parameter, which has not been described in literature previously, called percentage arterial enhancement, in which we calculated it as unenhanced phase HU minus early arterial phase HU minus enhanced HU divided by the unenhanced HU. Similarly, we calculated the percentage venous enhancement also. So our cohort, which consisted of 72 adrenal masses, mean age of the patient was 41 years. And in that, we could see that the maintenance of that adreniform shape, the ginger-like shape which is there for adrenals, was maintained only in infiltrative pathologies like metastasis and lymphomas. Size-wise, adenocortical carcinomas, as expected, were the largest tumor with mean size of around 10 centimeters, followed by lymphomas, and Pheos and metastasis were around 5 centimeters. As we can see, the Pheos, as is described in the literature, are actually light bulb-like appearance. They are very bright. So they had maximum HU as compared to other pathologies in arterial and early venous phase. And this is the typical pattern of a pheochromocytoma, as we can see that it takes up the contrast very rapidly so that it achieves the maximal contrast HU in the arterial phase in 20 seconds, and then it slowly washes out. As against the other masses like ACC and other masses where the uptake of the contrast is very slow, it goes on taking up the contrast late till venous phase and then it washes out. It was same for lymphomas and metastasis. So this figure tells us better that how pheochromocytomas stand out radiologically as compared to the adenocortical carcinomas, lymphomas, and metastasis in the sense that they take up the contrast very rapidly so that maximal contrast is achieved in an arterial phase and then they variably wash out. We applied an ROC and devised for this cutoff for the parameter that we had undertaken, the percentage arterial enhancement. So at a cutoff of 100%, we found that these have got reasonably good sensitivity at a specificity of 100%. That means if PAE is more than 100%, we can be close to 100% sure that this is PO and nothing else. So applying this study results back to our two patients whom I had discussed as the preface to this presentation. The first patient with the CA penis. So we did a detailed arterial phase CT scan for adrenal protocol CT scan for this patient. And we could see that arterial phase was close to 100 and the parameter percentage arterial enhancement was more than 100. That is, it was 156% for this patient. So on the CT scan itself, we knew that this is PO and we waited for the metanephrine reports. So typically in most of the laboratories, this metanephrine and normetanephrine are not routinely performed tests. So they generally run the samples in batches so that the reports are available within a week's time. And sometimes it may not be possible for the patient who has traveled from other districts to wait for 1 week. Nevertheless, this can give us some idea that this is a very specific parameter which can indicate that it can be a Pheo. And this was indeed a Pheo and he was operated after adequate alpha blockade. Second case, which was adrenal mass in the setting of lymphoma. Here also, when we did adrenal protocol CT, we could find that this parameter PAE was actually 400%, which is higher than 100%. And indeed, he also turned out to be pheochromocytoma, which was a normetanephrine secreting, confirmed on the biochemistry. So with this study, we concluded that a properly performed adrenal protocol CT adds tremendous value to the characterization of adrenal masses and pheochromocytoma to be in particular. And this wash-in parameters, which are based on taking an arterial phase, they can help to differentiate Pheos from other malignant adrenal masses with high specificity. And we have given certain cutoffs for these parameters. So this got published way back, a couple of years back from now. And I would like to quickly in 2 minutes go through our experience of bilateral adrenal masses. So this we published in 2016 after retrospectively analyzing around 560 patients in adrenal masses over last decade, out of which 70 patients, which accounted for around 12% of our all patients of adrenal masses, which were bilateral. And it happens to be the largest reported series till date. And the most common etiologies in bilateral adrenal masses out of these 70 patients were bilateral pheochromocytomas followed by tuberculosis. And the characteristics are intense contrast enhancement in bilateral pheos, while the TB, half of them had calcifications, and they were not that big masses when it came to tuberculosis. We had around 30% of the patients who had tuberculosis and 40% of the patients who had bilateral pheochromocytomas. Other pathologies that we had were bilateral lymphomas, adrenal lymphomas in 10%, and metastasis in 6%. Apart from that, we had certain rare pathologies like bilateral adrenal adenomas, which were there seen in 3 patients, and an emerging pathology, what we called as PBMAH, primary bilateral macronodular hyperplasias, that were seen in 3 patients, and the other etiologies like histoplasmosis, adrenal cyst, myelolipomas, leiomyomas, they were seen in 1 or 2 patients each. So comparing the characteristics of these two, we can see that lymphomas and metastasis, they have very short duration of symptoms as against the pheochromocytomas and tuberculosis, which have got minimum 1.5 years of symptomatology. And the hypocortisolism, that is adrenal insufficiency, was predominantly a feature of tuberculosis and lymphomas. A couple of words about bilateral pheochromocytomas. So very important here is whenever the tumor is bilateral, there has to be some underlying genetic or syndromic association. So out of these patients that we had in our cohort, 80% of them had, 70% of them had some syndromic or familial association. Out of these 70%, 80% of the patients had von Hippel-Lindau syndrome, and 4 patients had multiple endocrine neoplasia 2A syndrome, and 10% had MEN2B syndrome, signifying that whenever we see bilateral adrenal masses, we have to dig more into the family history and investigate more to rule out the syndromic associations of the tumor. Tuberculosis, as the characteristic adrenal calcifications that we always know of tuberculosis, that were seen in only half of the patients. Other half did not have calcifications. The size of the tumor was just 2 centimeters, and all of them had adrenal insufficiency. The diagnosis that was made was based on in 60% of the patient, there was evident extra-adrenal tuberculosis present, based on which the adrenal lesions were thought to be of TB, and AKT was started empirically, and the response to the treatment was taken as a proof that it was TB. But in 40% of the patients, they did not have any extra-adrenal manifestations of tuberculosis, and so the biopsy was done to prove the diagnosis. And the adrenal insufficiency which sets in, adhesions which sets in adrenal tuberculosis, is permanent, and they require lifelong corticosteroid and mineralocorticoid replacement. So based on our experience of these 70 patients, we suggested a management algorithm for patients with bilateral adrenal masses, that we have to do secretory profile and CT abdomen for these patients. If they have hyperadrenergic state, that is higher plasma-free normetanephrines, they would be Pheo. And if they had hypercortisolism, they can either be a bilateral adenoma, or they can either be a PBMAH, that is a hyperplasias. Adrenocortical carcinomas very rarely can be bilateral. It's mostly a unilateral pathology. Those who have either normal cortisol or those who are having adhesions, hypercortisolism, there we depend on the radiology to see whether it is adenoma, myelolipoma, or a cyst. And if it is not characteristic of either adenoma, myelolipoma, or a cyst, then we biopsy the lesion to find out the cause of the lesions. So here I would like to end my presentation. I hope I have strictly adhered to the time limits.
Dr. Swathi, thank you very much for giving us, I think, very important insights into bilateral adrenal masses. Are there any questions from the students, or questions and comments from the seniors here, please? All right, if there are no questions.
Dr. Swathi.
Yeah.
Yes.
Go on, Ravi. Yeah.
So there is a lot of this literature about adrenergic crisis in tuberculosis, and especially bilateral. Have you seen? It doesn't seem to be there much with you. And if
adrenal crisis, sir.
Yeah, bilateral,
Yeah, so
tuberculosis.
all our patients had adrenal insufficiency, 100% of them. So at the time of diagnosis, when they were not knowing, they presented as adrenal crisis, either with hypotension or with hyponatremia, or with just generalized weakness and severe hyperpigmentation. When they were evaluated, they were found to have hypocortisolism. So all of them had adrenal insufficiency, some of them presenting as crisis at the first time.
Okay.
I have one question, Dr. Swathi. There is a school of thought that when you have small secretory adrenal masses, okay, and you're quite sure on radiology that it's not malignant, that there is a role for medical treatment, particularly hyperaldosteronism. But I see that in your slide that you straight away said if it is secretory or if it's secretory or if it's malignant. I think that's the second one, that you must go for surgery.
Yes, sir.
Is that what is your view about this contrary view?
Yeah. So medical management for hypersecretory tumors is only in terms of Cushing's, hypercortisolism.
Yeah.
For hyperaldosteronism, there is a long-term data which is available that surgical treatment is much better in terms of long-term morbidity, because it relates to hypertension. So long-term morbidity with hypertension and cardiovascular outcomes are much better with surgical treatment than with medical treatment when it comes to hyperaldosteronism. And so if it is aldosterone secreting, the guidelines are that if the patient is young, less than 60 years old, we should go ahead with surgery. In older patients, if it is a surgical risk or something, then we can manage with mineralocorticoid antagonist, that is spironolactone.
Yeah.
And so far as it goes for pheochromocytoma, conservative management is generally not thought of unless it is very small, less than 1 centimeter.
Yeah.
And for cortisolism, there is a role for conservative management, especially if it is what we call as subclinical Cushing's. That means biochemically, there is hypercortisolism as per our cutoffs, but the patient is not frankly Cushingoid. So in that scenario, we can manage just the comorbidities, that is hypertension, diabetes, and we can give some ketoconazole or something to keep the cortisol secretion under control. So the medical management has a place, but largely surgical management has got better long-term outcomes than medical management.
Yeah, thank you. Thank you very much.
Sir, the one point to add,
Yeah.
see, I think Dr. Swathi is absolutely right. And the other thing is what they say is especially with the Addison's, the aldosterone secreting tumor, the need for hypertension, antihypertensives is so great, and many of the times the hypertension is very refractory, and even with multiple treatment, it doesn't come down that easily. So surgery is probably better because of that.
Yeah, I just wanted to highlight that there is a contrary view. It's for the information of the postgraduates, and there are large medical series which show that it can be managed in many cases. It can be managed conservatively, but the treatment of choice, I agree, is surgery, particularly in people who are not medically unfit. You would consider conservative treatment if somebody is very unfit and you're reluctant to operate on them, but otherwise in fit patients, surgery is the treatment of choice. Okay. Now, can I request Pawan to share his screen and give his presentation, please?
Sir, is my screen?
Yes, and you're heard well. Please go ahead.
Yes. Good evening, everyone. I am Dr. Pawan Kumar, second year DNB resident from Sagar Hospitals. We have discussed on adrenal tumors and their management in the last class, and we are continuing about that with ablations now. Ablation techniques. Ablation is an image-guided procedure which is preferred for patients who are not suitable for surgery, and most common complication of ablation is hemorrhage. Any previous CT or MRI should be evaluated before the treatment to know any vascular and non-vascular structures present next to the adrenal gland. This technique does not yield any resection specimen and need any follow-up. There are various methods of percutaneous adrenal ablation techniques like radio frequency ablation, cryoablation, microwave technique, and chemical ablation and irreversible electroporation. And
Pavan,
yes, sir.
I don't think we need to get into details of each one of those.
Okay, sir.
So just one line highlight of each of these kinds of ablation, and then you can proceed with the surgical techniques. Please go ahead.
Okay, sir.
Yeah.
So in radio frequency ablation, we are alternating current is used, and which causes coagulative necrosis of the tissues. And these are the various advantages of the radio frequency ablations, like it is a mini invasive procedure and faster recovery with widespread availability and economical. And regarding microwave ablation, in this the microwave range with a frequency of at least 900 megahertz frequency, which causes cell death from coagulative necrosis. And the advantages of microwave ablation is, as shown, it has higher intratumoral temperature with shorter application time and larger ablation areas and decreased pain during procedure. And cryoablation is also an image guided technique, and in this we use the temperature range of -80 degrees to less than -150 degrees centigrade, which causes disruption of the tissue cell membrane and causes coagulative necrosis. And these are the various advantages and limitations of the cryoablation. Like advantages like avoid damage to the adjacent organs and requires smaller doses of sedations and high clinical success rate. And the limitations like increased risk of hemorrhage and inability to coagulate tissue during probe withdrawal. And irreversible electroporation technique, which is also a non-thermal ablation technique. It requires use of general anesthesia. And chemical ablation is an image guided technique. Here we use chemical agents like acetic acid and ethanol is used, and it has less damage to the adjacent organs. So embolization, can I continue? Sir?
I think you should
Sorry.
have told the indications of.
Yeah.
Sir?
Srikanth, he mentioned the indication that these are ablative procedures or people who cannot withstand surgery. People who are poor surgical risks are offered ablation.
Oh, thanks. I didn't hear. Sorry.
Yeah. Okay, no problem. So, yeah, you can also have an embolization. Please continue.
Sir.
Yeah.
So adrenal gland embolization. These are used for pain relief in case of larger tumors with some compressive symptoms, and it helps to reduce in case of to reduce the tumor bulk and to reduce the tumor vascularity preoperatively. It is used for the treatment of hyperaldosteronism and traumatic injuries and adrenal artery aneurysms. Adrenal biopsy is used in confirming diagnosis of metastasis from extraadrenal cancers, and pheochromocytoma should be excluded before performing the biopsy to prevent precipitation of the potential hypertensive crisis. Recently, has a significant reduction and due to improvement in the non-invasive imaging techniques, adrenal biopsies have significantly reduced in recent years, and the common complications during adrenal gland biopsy is pneumothorax and hemorrhage. The disadvantages of the adrenal gland biopsy is there is a risk of seeding of adrenal cancer, and in case of undiagnosed pheochromocytoma or paragangliomas, before performing after performing a biopsy procedure leads to an adverse hemodynamic effects. And it is always possible to distinguish between a adrenal adenoma and adrenal cortical carcinoma.
Not always possible to distinguish.
Not always. Yes.
Yeah. Go on. Yeah.
And surgical management, sir.
Yeah.
Yes. Unilateral adrenalectomy is indicated in case of larger lesions. There is no absolute size for the size for recommendation. Larger the mass, higher the incidence of malignancy. Hence, surgery is recommended in larger lesions if the size of the tumor is more than 4 centimeters. Even the imaging characteristics suggestive of benign lesion. The perioperative care, we have to prescribe mineralocorticoid receptor agonists like spironolactone or eplerenone for patients with adrenal incidentaloma or primary primary hyperaldosteronism, and this is discontinued post-operatively to prevent hyperkalemia. Other antihypertensions are also stopped or reduced based on the patient's post-operative BP. If patient is successful despite of the successful surgery, in older patients on long-standing hypertension more likely to have irreversible vascular damage and persistent hypertension. Hence, antihypertension medications is continued. Adrenalectomy is a as adrenal gland is a difficult to access to the open incisions, laparoscopic adrenalectomy is considered as the gold standard treatment. Robotic assisted laparoscopic adrenalectomy has greater range of movements with improved magnification and stereoscopic vision. The advantage of this robotic laparoscopic adrenalectomy is we can perform in the patient with higher BMI and in case of larger tumors, but however it is costly and it requires longer operative time and significant learning curve. Posterior retroperitoneoscopic adrenalectomy. In this, we have to use high insufflation pressures in the retroperitoneal cavity, and it provides direct access to the adrenal gland. It allows bilaterally, we can able to proceed the bilateral adrenalectomies without repositioning the patient. The disadvantage of this posterior retroscopic adrenalectomy is it has a smaller working space and difficult to remove the larger tumors and difficult to perform on the patients with higher BMI. The advantages like it has reduced post-operative, it requires less post-operative analgesia and less hospital stay. These are the various adrenalectomy approaches as shown in the table, that is laparoscopic lateral transabdominal approach and laparoscopic posterior retroperitoneoscopic approach and open anterior transabdominal adrenalectomies. In case of laparoscopic lateral transabdominal approach, it is used in larger tumors and it has a wider operative field, and it is in this having greater versatility, and it is preferred in obese patients having BMI more than 35. In this procedure, 80 degrees lateral decubitus position with elevated kidney rest with 10th rib directly over the break point on the table. There are 3 or 4 radially dilated trocars along costal margin with 5 centimeters between 2 pores.
All right.
Yes, sir.
Pavan,
Yes,
why do you think you need a lateral decubitus in this?
Sir, so
if you have a left adrenal,
okay, sir.
What lateral decubitus will you have for the patient?
Sir, right decubitus patient, sir.
Why?
Sir, so that we can prevent the injury to the other bowel structure, so it will fall down to the dependent parts.
Correct. It's as simple as that. The bowel will fall down to the other side.
Yes.
And so on the left side, what would be the structures that you need to mobilize to reach the adrenal?
Sir, spleen we have to, sir, release from the adjacent
structures. Do you mobilize the spleen?
No, sir. We have to mobilize the splenic flexure, sir. And
splenic flexure of the colon. That's about
yes,
the only thing that you need to do. Okay. And on the right side, what would you do? Patient in the left lateral position, what would you mobilize on the right side to reach the adrenal?
Sir, right side we have to mobilize the hepatic flexure, sir.
Correct.
And we have to lift the liver.
Yes.
And with separation of the gerota fascia.
And Another important structure covers the adrenal.
Pancreas. Inferior
Duodenum.
duodenum. Yes.
Okay, you have to cauterize the duodenum and
Yes.
push it medially if
Okay.
you need to approach the adrenal. Okay,
Yes.
that's
Yes.
all you need to know at this stage. Okay, go on.
And sir, can I continue this?
Yes, yes, yes.
In case of laparoscopic posterior retroperitoneoscopic approach, it is preferred in the tumors less than 6 centimeters in diameter and also preferred in bilateral tumors. And in this procedure, it avoids anterior adhesions in the prior extensive abdominal surgeries and avoids extensive mobilization of solid organs. It has less working space. In this surgery, the patient is in prone position and 3 ports placed inferior to the 12th rib, and it requires high insufflation pressures. In case of open anterior transabdominal adrenalectomy, it is preferred in patients whose tumor size is more than 8 centimeters with clinical features like feminization and hypersecretion of multiple steroid hormones, and the image showing local or vascular invasion with surrounding lymphadenopathy and metastasis. In this kind of situations, we preferred open procedure. And in this, the patient is in supine position, and we will use subcostal incision or chevron or upper midline extension incision. In case of left adrenectomy, as we discussed now that initially we have to mobilize the splenic flexure, and then we have to do downward and lateral attachments of the spleen, and we have to do careful dissection with the tail of the pancreas and the splenic vessels. And left adrenal vein and small adrenal arteries are ligated, and watch for is there any superior renal artery branches there are. In case of right adrenalectomy, we have to mobilize the hepatic flexure and mobilize the right triangular ligaments and the liver anterior medially. And in case of we have to identify the plane between the adrenal gland and the inferior vena cava. Adrenal vein usually short and it is wide and variable, as we discussed in the earlier anatomy classes. So we have to see the adrenal vein variants anatomy through the methodical dissection and avoid venous bleeding. And various difficulties while performing adrenalectomy is so during adrenalectomy, communication with the anesthetist is very essential, as in case of Pheochromocytoma, it produces catecholamines and causes hypertension and tachycardia. Patients hence patients are treated preoperatively with alpha and beta adrenergic blockers. Any fluctuation in the blood pressure and heart rate during adrenalectomy will require an intervention by the anesthetist. In case of worsened hemodynamic conditions, the surgeon needs to pause the surgery to achieve that. Once the hemodynamic condition achieved, we can proceed to the surgery. In high insufflation pressure may cause increased blood pressure and heart rate, and the insufflation pressure may need to lower until the situation improves.
Right, Pavan.
Yes, sir.
Are you talking more about this preparation during your presentation on pheochromocytoma, or is this all you're going to say for the preparation of the patient for pheo?
Yes, sir.
Are you going to say anything more about preparation later, or is this what you have on preparation?
Later post procedure also I have.
Post procedure, okay. Even
yes,
preparation we need to understand as surgeons.
Yes, sir.
What is the kind of monitoring that you need to have, and what do you need in preparation apart from the alpha blockers and beta blockers? What is it that you need to be ready with for surgery? Hari?
Blood test. I'm not sure, sir.
Think about it, man. You're going to have a patient with a, you're giving, you've already given the exam, so I can't even say you're going to give the exam. Yeah, I mean, what are the patient is going to have a labile blood pressure, okay?
Yes, sir.
And soon after, you understand that the hyperadrenal state would have caused severe vasoconstriction. And when you take out the tumor, because of this lack of the adrenal medullary hormones, there is a huge vasodilatation.
Yes,
So
sir.
what does it lead to?
Hypotension, sir.
Yes. Okay. It leads to relative hypovolemia, and so it leads to hypotension. So you must be prepared for this.
Yes.
Hypertension during surgery when you handle the tumor, and as soon as you remove it, severe hypotension, for which the anesthetist must be prepared. So what are the things that you do? You don't have to mug it up. You can work it out. So you must know the fluid status of the patient. So what should you know? What should you have to know the fluid status?
IVC.
Sorry?
IVC, sir.
IVC. Don't worry about the IVC. CVP.
CVP.
Nothing
Yes,
dramatic. Okay.
Yes,
So have big venous access where the anesthetist has the capacity to push fluids quickly
Yes.
and monitor the central venous pressure.
Yes.
So you have a normal CVP when you start, and you need to have a thorough knowledge about or thorough monitoring of the blood pressure. So what would you have for that?
Central lines.
Central line for blood pressure?
Arterial lines.
Thank you. So you need to have an arterial line. All right.
Yes, sir.
And you need to have monitors, pressure transducers hooked up so that you're constantly monitoring it. So if you have, when you're during the operation, if the pressure goes up, what should you do?
Bit hypertensive, sir.
What should you? Sorry?
Intraoperatively vasopressors or
Vasopressors, hypertension we're talking about. So the first thing the surgeon does is he stops the operation, pauses the operation, not stops completely. Okay. Pauses the operation so that you do not handle the tumor, you do not push any more medullary hormones into the circulation. But that is not enough. The anesthetist must be ready with 2 medications, acutely acting medications which can be titrated intravenously. What are they? This is extremely crucial for all surgeons to know. It is sodium nitroprusside and labetalol. Okay. Please read up about the details. There is no specific dosage because it has to be titrated, but you must have these drugs readily available, mixed up and ready for infusion. So once if the pressure goes up, you pause the operation, the anesthetist starts pushing the nitroprusside, brings the pressure down, and then allows you to operate again. Okay, this is very important. And as soon as the tumor is taken out, you must give some time for the anesthetist to fill the patient. The patient, because of the relative hypovolemia, because of the lack of vasoconstriction, or it opens up the circulation, the anesthetist will need time to fill up the patient, thus avoiding hypotension. You understand that? And this process lasts a few hours. And so with careful CVP monitoring and careful fluid infusion, you can avoid catastrophic hypotension. That is what you need to know. Okay. And of course, the big problem, particularly with adrenal surgery, when somebody is hypotensive, is whether the patient is bleeding inside or not. And that is something you manage by looking at the serial hemoglobin administration, looking at the drains for possible bleeding. And if there is the slightest doubt of bleeding, you have to re-laparoscope them with a low threshold, because bleeding from one of the slipped clips on the veins is like bleeding from IVC or from the renal vein. If it's the left side, it is the renal vein. If it's the right side, it is the IVC. So you do not have a lot of time to hang around and watch the patient. So you must have a low threshold for re-laparoscoping these patients. Okay, got that?
Yes, sir.
Yes, sir.
All right, go on, Pan.
Yes. So, in case hypercapnia is caused by carbon dioxide insufflation, and it can be managed by hyperventilation of the patient. And in case of laparoscopic and retroperitoneoscopic procedures, carbon dioxide embolism, which is a rare complication, can be seen. Any bleeding from the small veins or arteries can be prevented by cauterization or ligation. bleeding from the larger veins or arteries. In case of bleeding from the larger veins, it can be slowed by increasing the insufflation pressure in laparoscopic or retroperitoneoscopic procedures. Any ligation in the upper pole branch can cause ischemic renovascular hypertension. Injury to the main renal artery requires immediate action like ligation of the artery or tight pressure. Brisk
No,
bleeding.
You
Yes,
do
sir.
not. You do not ligate the artery.
Yes, sir.
You open up and control the bleeding.
Control.
Yeah.
Okay, sir.
Go on.
Brisk bleeding and delay in the control can lead to ischemic kidney injury. It requires immediate conversion to open surgery and reanastomosis may require. Sir, can I continue this role of?
It is. Yeah. It's now 9:52.
Yes, sir.
What I thought we would do, we'll do the rest of it in the next class. But I can share with you
Yes, sir.
the laparoscopic adrenal ectomy video that I have on the cases that I have done. I'll show you 2 of them. I've done a total of 6 so far. These are not great videos. They were in the single chip camera stage. Before that, Ravi and other seniors, you have any comments to make about the surgical steps that may be of use to the students?
Sir, muted, sir.
Ravi, can you come in and see if you have any comments?
Yeah, I think he has covered everything quite well. I think the only point to note is the adrenal vein, which we think it is not going to be a problem, but that is the one which can sometimes beat quite heavily. So I think adrenal vein, whenever you isolate it, identify it, you have to be very careful in getting controlling, getting good hemostasis with that. I think that is the only point I can think of.
Yeah. Shrikant, any comments?
No, sir, I don't have much experience in this.
All right. What you're seeing is the mobilization of the left colon. This is I think it was a 14-year-old boy at that time with what's called a Carney's complex. He had bilateral adrenal tumors, cortical tumors, not Pheos. He had a cancer of the thyroid. These people and a tumor of the pituitary. This is a hereditary disorder sent to me by one of the endocrinologists, and we did in the same instance a bilateral adrenalectomy. Okay, and you can see that I'm mobilizing the hepatic flexure of the colon. I'm going to basically show you the adrenal vein. The arteries, as we discussed earlier, are many. This is the tumor that you want to see. Okay, this is the tumor. And even though the book sometimes mentioned that you have to mobilize the spleen, many times you don't have to. You just have to divide it here. And in the ones that I have done, I have never detached any of the spleno linear. What is that called? Spleno linear ligament. That is the one to the diaphragm, because you don't want the spleen to fall forward like this. So you just have to mobilize the attachment of the hepatic flexure to the spleen. There, the hilum of the spleen is there. Okay, I'll skip through this, and hopefully it will make sense, even though I'm skipping through. Okay, let me come to about 9 minutes. Okay, can you see the vein now? The arteries are taken around the thing, but this is the adrenal vein, and this is the renal vein. It is entering the renal vein here. We have clearly seen and delineated. We used normal clips there, but a Liga clip which locks on the other side is always preferable. We had no access to that at that time, and so we used this kind of clipping for the adrenal. Okay, an ordinary clip that we use on the metal clips. And so because we were very nervous, we used, I think, 3 clips on the renal vein side. I'll then skip to the right side. That will be 23 minutes. Just give me some time. I have sort of marked it earlier in the day to make sure that I don't spend too much time. Okay, we've now come to the right side, and you'll find that the liver comes pretty much in the way here. What I'm doing is dividing the peritoneum in front of the IVC. Okay, this is the adrenal tumor. This is the kidney. I hope you can see my pointer. And this is the IVC down here. Right here is the IVC. I'll skip 2 minutes. And now you can see the IVC pretty much bared. This is the IVC here. This is the liver. It goes right behind the liver there. This is the kidney. And this is the adrenal tumor right there. Okay. And the right adrenal vein is a lot more tricky than other veins. I'll go to 28 or 26 maybe, and see if I can show you the dissection of the adrenal vein. Now, this is the adrenal vein, not completely delineated yet. You still have some other structures. This is the tumor here. This is the tumor, and this is the IVC where you see my pointer, and this is the right adrenal vein. Some other small veins that are coming directly from the IVC onto the adrenal. And once you dissect it out completely, okay, you can see the adrenal vein come out quite well. And I'm now clipping the adrenal vein on the right side. Okay, this is the first clip on, this is the IVC. This is the first clip on the adrenal vein, and this is the actual adrenal vein there. Okay, you can see the vein go there, and the way your ports are placed, when you do it on the right side, because you need to get a 10 mm clip, we didn't have the 5 mm clip applicator. We are applying the clip with our left hand. So that's where our 10 mm port was. So that is the first adrenal. I'll show you another one. This is a left adrenal ectomy. Again, as I said, the spleen need not be mobilized very much. This is the hepatic flexure being mobilized. It's good to have washout from time to time because it does bleed a little bit, and have a gauze piece inside so that you can suck things out. And around the adrenal, you can quite nicely do a hydro dissection also, blunt dissection. You'll see small vessels come in, which you can cauterize either with a bipolar or with harmonic if it's available. And I'll again skip to the adrenal vein part of it. Okay, so this is the renal vein. Remember, this is the left adrenal ectomy, and it's a little more easy to do it on the left side. You would expect the adrenal is mobilized all around there. Up there is the spleen in the upper right corner of your screen. And we're now trying to identify and clean the adrenal vein. You can see it coming in. This is the vein. You see it just coming in into your view. And where we were squeezing up there, this is the renal vein here. So you can see the adrenal vein right there now. Okay, and this is the renal vein underneath the Maryland that you can see. That is, I'm just pushing it down, getting a better length on the left adrenal vein. Okay, and then you can put a right angle around it, create space all around the adrenal vein, like so. Okay, and you have enough length to apply your clips. Okay, so I'll stop here, and stop sharing. And just to give you an idea of how the adrenal vein looks, I have no experience of retroperitoneal approach. Everything that I have done has been a trans-abdominal approach. And it actually is not as difficult as it sounds. The right side, it can be sometimes difficult dissecting under the liver, but by and large, you will be able to get the dissection without too much bleeding. Before we close, final comments questions from the students, if any, and final comments from the seniors. All right. Shrikant, any comments or questions?
Nothing, sir. I came little late. Who was the first presenter, sir?
First presenter was our endocrinologist, Dr. Swathi from Sagar.
Okay.
Yeah.
Thank you.
All right. Abdul, questions, comments? Kavya?
No, sir, nothing.
You guys have to be more vocal here. Kavya and Abdul, you are the middle grades. You need to talk, because very soon you need to take over from me. Huh? Kavya, comments?
Ma'am is in emergency, sir.
Ma'am is in an emergency. All right, good. Ravi?
I think Swathi is excellent. Insight into the various controversies and problems, and also the diagnostic tests that are applied appropriately. I think she is very, very good, and the flow of thought and the presentation was excellent. And I think Pawan also presented well. Only thing is actually, so they say that this retroperitoneal the retroperitoneal this one laparoscopic retroperitoneal
Approach,
dissection
yeah.
approach is supposed to be much faster and much better. I have, as you said, I have no experience. I've only done transabdominal, and but people say that, especially there is one fellow who does it very well, and bilaterally in 40 minutes he finishes.
Yeah,
which I think is excellent, but I have no experience with that.
All right. Thank you. I think I agree that Dr. Swathi gave us a very good presentation. Pawan did a good job as well. I need your view. There are a few more slides that Pawan has. He had 79 slides for a 40-minute presentation. My personal view is that we should stop adrenal here. We have discussed it at length over 3 sessions, and that Pawan can share the presentation on the group WhatsApp, and others can learn about it. And if they have any questions, they can ask those questions on the WhatsApp group, and we can answer that. Or if the majority of you prefer, we can have one more class, even though my own view is that we have pushed adrenal pretty hard these 3 sessions.
Yeah.
What do you say?
I think presentation into the group, and then discussion in case there are any questions or doubts.
Right. Okay, fine. Thanks, Pawan. So please put your presentation. I can also attach it to the WhatsApp group. If people can go through it, read up about it, and if you have any questions, please post them on the group so that we can try and answer those if we know the answers. Okay. Thank you very much, and good night, and thank you for your participation.
Good night, sir.
Good night.
Thank you, sir.
Thank you.